All right, today we're going to be discussing Chapter 4 in your Fallon book, which is on the radiology section of your CPT-4 book. There are 4 subsections of this section, which is your diagnostic radiology, your diagnostic ultrasound, your radiation oncology, and your nuclear medicine. Some examples of your diagnostic radiology procedures would be your CT scans, your MRIs, your angiographies, your mammographies. The main term that you're going to look under for this section in your index is X-ray, and the subterm is going to be the specific test in which you run. There are 3 components that are a part of these codes, and we've already talked about this, but I'm going to reiterate it. You have the professional component, which represents the physician portion of the service. It does include the supervision of the technologist taking the film, as well as the interpretation of the results to include a written report. The technical component is the technologist service. Really, it's the overhead in which it takes to take the film, and then the global is representing really both professional and technical components of the radiology services. There's several properties that exist in order for X-rays to be taken. There's some radiant energy that can be useful with the diagnosis and treatment of diseases. X-rays use ionizing radiation or high-level energy that have particular qualities that are helpful to physicians to diagnose diseases and injuries and to treat certain diseases such as cancers. So in most cases, an image is taken to really verify the existence or absence of something. An example would be an existence of a bone fracture or a foreign body, or to check on the patency, meaning how open a particular organ could be or would be, such as your fallopian tubes, whether they're open or whether they're closed and inhibiting you from becoming pregnant. A radiolucent substance or structure in the body allows the passage of most of the X-rays, and then by allowing the X-rays to pass through the object, it appears black on the X-ray film. Lungs is a good example of a radiolucent structure, so with the air in the lungs not absorbing the X-rays. So conversely, radiopaque substances or structures absorb the X-rays, thus they produce the distinct image on your X-ray film, such as bones. Bones are going to absorb the X-rays, and they're going to only allow a small amount of X-ray to pass through to the X-ray film. Another example would be when fluid is present in the lungs, as in pneumonia. That's why they want to take a chest X-ray to either confirm or refute the diagnosis of pneumonia. All right, so just to reiterate, radiolucent substances, they do not absorb most X-rays, and they appear dark on X-ray films, and they use contrast media to enhance that ability. Radiopaque substances are ones that do absorb X-rays, and they have distinct images on your X-ray films, such as bones. Bones absorb the X-rays, therefore their image will be quite evident on the X-ray. All right, so again, just to reiterate, the importance of X-rays or radiology is to, again, verify the existence or absence of something, to verify the status, to check on patency, meaning how open or closed a organ could be or not be. Contrast media that's injected into you prior to having the radiology procedure done will enhance those images that they're in need of. And then radiation therapy is used to treat neoplasms. Body planes and X-ray positioning does play an important role. The correct positioning of the patient is critically important in both diagnostic and therapeutic radiology for accuracy and to really avoid repeating X-rays unnecessarily. So you're avoiding excessive exposure to healthy tissue. It is important for diagnostic studies to obtain the best possible image. It's also important for therapeutic modalities such as radiation therapy to treat the diseased tissue. I used to take X-rays way back in my early days of my career where I did get my license, and I took the most familiar films that I was accustomed to is taking of the back, the cervical, the thoracic, and the lumbar spine in the various positions that were necessary, as well as chest X-rays. The anatomical position, which this should be a review, you should be learning this in A and P as well as your med term, refers to the patient that's standing erect, facing forward, toes pointed forward, and palms open with the thumbs pointing away from the body. X-ray positioning, you have posterior, anterior, which in terms of radiology, it's P to A. Anterior posterior is A to P, supine, lateral, and oblique. So the posterior anterior X-rays are taken from back to front. Typically they're going to take a PA from the chest, if you will. In order to get a really good, you have to breathe in, take a deep breath in and hold it so that they get a good image on doing that particular X-ray film. Anterior posterior X-rays are taken from front to back with the film in the back. So what that means is there's a bucky or a table, if you will, that holds the film. And the first posterior anterior example that I gave you with the chest X-ray, literally the chest is going to be up against that bucky or that table with the head turned and with the shoulders rounded, if you will, with your arms up at the very top in a relaxed state. And like I said, they usually take a deep breath in and they hold it for you to take the film. Anterior posterior is the other way, where your back is up against the bucky, which is closest to the film. And typically anterior posterior is a good position, of course, to take films of your lumbar spine. All right, so just a real quick review on body planes and your X-ray positioning. The frontal position is where the body is cut vertically, anterior and posterior, like you're cutting the body in half, if you will. Posterior anterior position is in the frontal plane. Sagittal is the body cut vertically from right to left, right and left parts, if you will. And the lateral position is in the sagittal plane. And then the transverse is where the body is cut horizontally, upper and lower. And this is where the CT scans slice the body to view internally. So if you look on page 98, you can see the pictures that represent these body planes and X-ray positions. All right, so talking about modalities, a modality is a form of application or use of a therapeutic agent or regimen. So the radiology section of CPT is divided by modalities. Modalities meaning like your diagnostic radiology is going to have your plain X-ray films, your X-rays with contrast, your CTs, your computed tomographies, your MRIs, your magnetic resonance imaging, and your vascular procedures. The vascular procedures, you're going to need codes from the surgery section possibly. As well, you have interventional radiology, which also has surgery codes as well as the radiology codes. The diagnostic ultrasound modality will have codes for obstetrical and non-obstetrical services. Radiologic guidance is for your pericardiocentesis, your thoracentesis, and your amniocentesis. Biopsies, radiation field insertion, and your aspiration of the ova. Of course, the amniocentesis, those centesis is your withdrawing fluid. So the pericardiocentesis is your withdrawing fluid, the sac that surrounds the heart, if you will. Thoracentesis is in the thorax area of your body where you're withdrawing fluid, and amniocentesis where you're going into the amnio sac of a pregnant woman and withdrawing fluid. Anytime that you're withdrawing fluid from the body, that fluid and substance is going to tell the story of what's happening within that patient. So if it's clear, then all is good. If it's cloudy, it could be indicative of infection or cancer, if you will. If there's blood in it, it could be indicative of internal injury, of course, internal bleed, so you have to pay close attention to the source of that. So again, it tells the story based on what is obtained within that fluid. Mammography, you have the screening, of course, and then you have the diagnostic tests that are done. Okay, continuing on with modalities, you have bone and joint studies, you have your radiation oncology to include external beam radiation, brachytherapy, which is the insertion of seeds or ribbons within a particular area of a neoplasm requiring treatment. Nuclear medicine is going to be using radioactive substances, gamma rays that are emitted and detected by the scanner. Okay, contrast media, we said earlier that it does assist in the viewing of the objects, if you will, within the film. So to be classified as with contrast, contrast media must be administered one of the following ways, either intrathecally, intra-articular, and intravascular. So intra means within the cavity, within the artery, within the vessel, if you will. Okay, continuing on with the contrast media, you have a modality, the barium enema, which is a special X-ray exam that's used to detect changes or abnormalities in the large intestine, also called the colon. There are two types of barium enema exams. One is a single column barium enema, where it begins by coating the inner surface of the colon with a solution that contains the metallic element barium, and this is going to allow the doctor to see a silhouette of the shape and condition of your colon. And then the other is an air contrast barium enema, which during an all contrast air contrast barium enema, air is inserted into your colon, and then the barium coating is put in place, and then the air expands the colon and improves the quality of the X-ray images. A barium enema doesn't require sedation, however, it will assist with you relaxing and having this performed. The barium enema does use contrast. Use of contrast is not specified in the codes. The barium is the contrast. Air can be added, like I said, for more contrast. KUB stands for kidney, ureter, bladder, which is often done as a scout film. You will hear it referred to as a scout film, which is not coded separately. Okay, supervision and interpretation. Some radiologic procedures have an invasive component such as your interventional radiology, which you're not going to learn a whole lot about in basic, but you will learn it in the intermediate CPT-4 class. But really, it's the radiologist procedures are coded to signify the radiologic supervision and interpretation. If he or she performs supervision of the performance of the procedure and provides a written report of the findings. The radiologist may also perform the invasive component, which is usually represented by a code from the surgery section of CPT. Again, it's called component coding or component coding, and interventional radiology does require that. It requires a code from the radiology section, and it requires a code from the surgical section. The example given in the book is a cholecystectomy, which is the surgical removal of the gallbladder, often performed laparoscopically because of the presence of gallstones. Before completing the surgical procedure, the surgeon would request a cholangiogram to ensure that there were no gallstones remaining in the biliary tree. And that, so for the radiologist billing, the supervision and interpretation code would be 74300, and for the surgeon's billing, it would be 47563. Charge master and superbill. Anytime that you hear the word charge master, you should always affiliate it with hospitals, and anytime that you hear the word superbill, you should affiliate it with the physicians. Both are listings of procedures that are performed either within that department or within that office, and they're checklists, if you will, as to the services that were performed. Sometimes it has ICD-9 codes on them as well. Both do require ongoing review for code updates. Truly, this is a job that could be available for a 2-year RHIT student as well as a coder biller student. Although they do look for higher education for charge master maintenance, if you will. But truly, these people can make up to 6 figures, truly, because of the impact that it has on the billing and the reimbursement of that facility. Okay, again, common modifiers that we've already talked about. 26 is the professional component used by the radiologist to bill for the time performing and interpreting a procedure. The TC is your technical component, which is used by the facility to bill for the overhead that it took to take the film, the x-ray, etc. If there is no modifier that's used, the payment will represent both components. Modifier 50 represents the bilateral procedure. You have unilateral x-rays being taken, and you also have bilateral procedures that are taken. RT, LT are used with extremities as it relates to radiology. So if they're just taking the x-ray of the left knee, then of course you would put the service or procedure code for the radiologic x-ray for the left knee, and then you would append LT onto it. 52 is reduced services. Screening mammogram is a bilateral procedure because again they're screening and they're looking at both sides, both breasts, for comparison purposes. Some codes do specify minimum views that need to be taken in order for you to code with that particular code. Procedure is canceled after preparation but before initiation of procedure. These are instances in which you would use modifier 52. Modifier 59 is distinct procedural service. Secondary procedure performed independent of the primary procedure. So appending 59 is telling the payer this was separate and distinct from the primary procedure that's billed. Maybe bundled services, and as long as the service is performed separately from the primary service, it can be coded. Okay, modifier 73 is where the procedure is terminated after being prepped for surgery, but prior to or before the induction of anesthesia at the beginning of the procedure. So that's the key word, before anesthesia was started. 74 is where the procedure is terminated, but the anesthesia had been inducted, so procedure is terminated after anesthesia was administered. Modifier 76 is procedures repeated or reviewed by the same physician on the same day. 77 is where the modifier is assigned if the repeated procedure is performed by a different physician. Okay, CT scans, computerized tomography, they use two-dimensional X-ray images taken around a single rotational axis to generate a three-dimensional image of internal structures. The CT scanner does emit X-ray pulses that take pictures of a thin slice of the body area being studied. The scanner can tilt to take pictures from different angles. The images are then saved on a computer, and then the CT scans are often performed first without and then with contrast for comparison purposes. Contrast is useful to make certain tissues stand out against other tissues. Doing both forms of the procedure provides a more detailed diagnostic scan for the radiologist to interpret. MRIs are scanners that send magnetic radio wave forces many times stronger than the magnetic field of the Earth through the body. The resulting effect on the body's atoms forces the nuclei to move into a different position, and as they move back into place, they send out radio waves that was picked up by the scanner. A computer turns the waves into a picture. Very similar to the CT scans, the MRI scans may be performed with or without contrast. There's an actual picture, figure 412, that you can take a look at, the mid-sagittal MRI of the brain. Okay, mammography there's two categories. There's screenings and there is diagnostic mammographies. Screening mammograms are usually performed annually. They're usually performed on asymptomatic patients, meaning they are not encountering any symptoms to indicate having a mammogram done. And they are coded as bilateral. The intent is to do it bilaterally, again for comparison purposes. Usually when taken, there's two views that are done. But additional views can be obtained as well. The number of views is not a determining factor in coding a mammogram as screening or diagnostic. Computer-aided detection codes are add-on codes. These CAD codes produce a digitized image to be correlated with the screening or the diagnostic mammographic images. And then after correlating the mammogram images with the computerized aided detection codes, the additional information produced by the CAD may allow the radiologist to detect an abnormality at an earlier stage than without the CAD. So it's an additional supplemental ability to detect early cancer. Diagnostic mammograms are ordered when a physical exam reveals a suspicious mass or lump in the breast. The patient either has an abnormal screening mammogram or the patient has a history of benign or malignant breast disease. The code for the diagnostic test, the understanding is for it to be unilateral. And again, they have computerized aided detection codes as well for the diagnostic mammograms. In making medical necessity determinations for CT scans, you're going to take into account the presenting symptoms and the initial diagnoses. As well with the MRI scans, you're going to take into account the signs and symptoms as well for your medical necessity determinations. The medical necessity piece for screening mammograms, age requirements do vary by payer. Here's some samples. Younger than age 35, it typically is not paid. Ages 35 to 40, one screening mammogram paid for every 5-year period. And then if you're older than age 40, one is allowed per year. Again, with managed care as well as consumer-driven programs. They're obviously looking for us as the consumers to be more responsible with our health and do encourage preventative medicine, which that's what screening mammograms are, particularly if you have a history in your family. Medical necessity for diagnostic mammograms, patient has one of the following. Either there's a distinct indication for the mammogram, there's personal history of breast cancer or biopsy-proven breast disease, or there's an abnormal screening mammogram. Okay, ultrasound coding. First of all, we need to understand what ultrasound is, which is the use of sound waves to produce images of internal body structures. The codes are described as either being limited or complete. The coder needs to read the notes within the diagnostic ultrasound subsection very carefully to make a determination what really constitutes a complete exam. If a complete exam is not carried out, then a limited exam code must be assigned. An example, you could have a real-time ultrasound of the gallbladder with image documentation. The code would be 76705. One-dimensional ultrasounds can be either A mode or M mode. The A mode refers to the amplitude of the sound waves, whereas the M mode includes amplitude and the velocity. The M mode ultrasound includes recordings of body structures with these two characteristics, amplitude and velocity. The display is shown by dots with the strength of the sound waves being given in brightness. The stronger the echo, the brighter the corresponding dot's going to be. Two-dimensional ultrasounds are B scans and real-time scans. Similar to the M mode, the B scans use the brightness of the dots that are determined by the echo strength. So the B scans again use the echo strength to determine the brightness of the dots on two-dimensional display of anatomic structures. The resulting image is a two-dimensional display. The real-time scans include display of both structure and motion with time in a two-dimensional image. The example would be getting an ultrasound of your uterus, okay, to see the baby would be a good example. Okay, nuclear medicine coding. Diagnostic nuclear medicine studies usually use specifically formulated pharmaceuticals that emit your gamma rays. There's certain organs that will take up the pharmaceuticals, and then the resulting gamma rays are detected by the gamma camera and images are produced. The radiopharmaceuticals can be inhaled, ingested, or injected. The images show the organ or tissue activity and the viability of those organs or tissues. And a common well-known diagnostic nuke med test is a bone scan. This procedure is usually completed after cancer is diagnosed to determine whether there is bone metastasis or spread to other areas. Okay, positron emission tomography, or PET for short, and single photon emission computed tomography, SPECT scanning, measures certain functions of the body. PET scans of the heart are performed to assess the viability of the heart muscle, the metabolic activity of the heart, and the perfusion of the heart muscle. Perfusion is the blood flow, the circulation that supports the healthy cells. When the heart is injured or diseased, that blood flow is inhibited, and that inhibited blood flow is going to damage the heart muscle cells and affects its function. Okay, looking at the single photon emission computed tomography, it's a 3D computer reconstructed slices of an organ. These 3D images are obtained by the gamma camera rotating 360 degrees around the patient, who is positioned on an imaging table. For heart tissue, the slices obtained can delineate myocardial tissue from non-myocardial tissue. Okay, so talking more about the nuclear medicine coding aspect, you have a sentinel node scan that helps determine first lymph nodes to a cancerous tumor, and how this test is performed. It's performed under mammographic guidance, particularly for breast cancer. There's a fine needle that's placed in the tumor for localization purposes, and then the area surrounding the tumor is subsequently injected with a pharmaceutical. And the radioactive tracer migrates to the sentinel node, and then a nuclear scan is performed to determine the location of the sentinel node, and then this enables the surgeon to remove only specifically the affected lymph node and leave the other healthy nodes in place. Iodine pills, this is nuclear medicine, can also be therapeutic in nature, where the others were diagnostic as well to assist in treating. But iodine pills is therapeutic in nature, and they are ingested by patients being treated for a hyperactive thyroid, which cause ablation or destruction of the thyroid tissue. Iodine is the preferentially taken up by the thyroid to manufacture hormones that are important to our metabolism. The supply of the radiopharmaceuticals is not included in the CPT code, so to receive payment for the supplies, the facility billing must also include the HCPCS Level 2 codes. All right, interventional radiology procedures, as I indicated earlier, is considered component coding because you're going to be getting codes from the surgical section as well as codes from the radiological section. The procedures, the interventional radiology procedures, can be diagnostic, therapeutic, or both. The procedures do begin with the introduction of a catheter into a blood vessel. And really, a catheter is very thin. It's a tiny tube that's inserted into an artery or vein for a variety of reasons, and really such as to withdraw or instill fluids or dye in that area to again check the integrity of that vessel or artery that it's injected into. The puncture. The puncture is assigned a CPT code from the surgical section. Other surgery codes are assigned for moving the catheter into additional vessels. Surgery codes may be reported by a radiologist or a surgeon. The interventional radiology procedures also require a supervision and interpretation code from the radiological section. All vessels injected with dye and areas imaged are coded and reported by the radiologist. All right, so you have non-selective placements and you have selective placements of the catheter that was accessed. The puncture of the site is coded, and based on how that catheter is manipulated, if it is just to reside in the aorta and does not bifurcate to other branches of that area, then that's considered a non-selective placement. The catheter is accessed into an area and is placed in the aorta and stops. It does not manipulate or be moved anywhere else. Again, that's called a non-selective placement. Okay, so we learned about the non-selective placement. Now we're going to learn about what a selective placement of the catheter means. And what that actually, when you hear selective, again, the catheter has to access a puncture site. The catheter is moved either up through the vena cava or the aorta and beyond, and can be either contralateral, which is being manipulated on the opposite side of the body, or ipsilateral, which is the same side of the body. And based on the destination of that catheter will dictate the points in which you code. You want to reference the Appendix L for a depiction of what represents first branch, second branch, third branch, because again, selective placements is the actual moving of that catheter beyond the aorta or beyond the vena cava and into the various branches or vascular family trees, if you will. So again, take a look at Appendix L. Okay, vascular family, this is what I was referencing. The first order selective catheterization is your first branch that's studied. The second order selective catheterization is your second branch that's studied, and so on. Your third order selective cath is your tertiary branch studied. You want to code the highest order of selectivity for each branch that is studied. Again, we're going to do more of this in intermediate. I'm introducing this concept to you, but have no expectation, if you will, to synthesize and code accordingly. These are advanced concepts. Okay, continuing on, an angioplasty uses a balloon to dilate a narrowed vessel. The angioplasty codes are assigned per vessel that's treated, not per stenosis. Again, it's per vessel treated. So if you are in one vessel but are treating 3 areas of that vessel, you are only coding per vessel treated. There's 3 categories for the supervision and interpretation. And those categories are the peripheral artery, aorta, renal, or visceral artery, or venous. And again, those are your radiologic S&I codes for the angioplasty. Stent placement, again, is coded per vessel treated. Stent placement can be performed in conjunction with the angioplasty, so they may repair the vessel and then insert the stent, which is a wire mesh unit, if you will, that keeps that area open versus stenosing over. And the codes are assigned per vessel treated, not per lesion treated. The catheter placement is coded as in diagnostic angioplasty, and the angioplasty can be coded separately if there is a suboptimal result. Treatment is of an area not treated by the stent, or treatment is for dissection or stent-induced stenosis. Follow-up angiogram is not coded because it is bundled with the larger stent placement procedure. Okay, radiation therapy is treatment for cancer that's supervised by a radiation oncologist. The therapy is delivered either externally or internally. In either case, the objective is to kill the cancer cells while sparing the surrounding healthy tissues. This is done with ports to direct radiation into a specific area, and blocks to shield the healthy tissue from the radiation. With the external beam radiation, the high energy rays are directed at the cancer. Brachytherapy is the term for internal treatments. This is a treatment where radioactive seeds are implanted into the diseased tissue. Both external beam radiation and brachytherapy may require multiple treatment sessions. A large radiation dosage may be divided into portions, and this is often referred to as fractionation. Okay, patients' initial encounter with a radiation oncologist will allow for really the review of the patient's H&P. The history clinical picture is to determine whether the patient is a true candidate for radiation therapy. Codes for these consults are in your evaluation and management section. Follow-up office visits for counseling and recommendations for care are also coded from the E&M section. The radiation therapy codes do begin with clinical treatment planning. These are assigned by the radiation oncologist based on whether the planning process for patient treatment is simple, intermediate, or complex. In planning for radiation therapy, the physician must take into account possible surgery and other therapy tests to determine the size and depth of the tumor. to be treated. Calculation of the radiation dose is to be delivered, and then any necessary ports for delivery of those treatments. After the factors have been considered, the physician determines a prescription for treatment. Calculation of the radiation dose to be administered is called dosimetry. The dosage is calculated in units of absorbed radiation called rads and grays, which is GY. 100 rad units equals to 1 GY. This must be carefully calculated to ensure the correct depth and strength of the therapy. During these calculations, the size and the shape of the ports are determined, and then there's precise dose delivery that's important for optimal patient treatment. So brachytherapy does involve the insertion of a radioisotope that's inserted internally. The radiation sources can be implemented permanently or temporarily. So you have sources or seeds that may be permanently or temporarily, which are ribbons. The corresponding codes are divided into either simple, intermediate, and complex. A simple application has 1 to 4 sources or ribbons. A complex application has more than 10. Codes are also given for the approach being intracavitary, interstitial, or surface applications. In addition, CPT provides codes for high-density brachytherapy depending on the number of source positions or catheters. The radiation therapy is administered through the catheters directly at the tumor being treated, again trying to preserve the healthy tissues around that tumor. Intracavitary brachytherapy is delivered into the cavity, such as the uterus, in the treatment of cervical cancer. Interstitial brachytherapy is delivered into the tissue, such as the prostate gland, in the treatment of prostate cancer. Okay, this slide does conclude Chapter 4, where we reviewed the various services that are represented in the radiological section.